Tongue tie can permanently affect the oral structure and can cause orthodontic and other dental issues.
I'm Dr. Jain. I'm a dentist in Vancouver, and I do quite a bit of tongue tie release. I do primarily infants with breastfeeding problems, and I also do quite a few adults as well who have ramifications, negative effects from their tongue tie. The primary one is constriction, narrowing of the arches, because the tongue isn't allowed, because it's constriction to the floor of the mouth, it isn't allowed to make the full range of movements to allow it to spread out and become a nice wide tongue. It tends to be more narrow and thick in the middle, and because we have cheek muscles on the outside as well as the tongue muscle on the inside affecting the actual shape of the arch in development and also into adulthood as well, that leads to that narrowing arch and inadequate space for the teeth to come into line, and also inadequate space for the tongue, which can lead to tongue biting, which can be quite severe for some people. The other thing we see from a dental perspective when a tongue is tethered to the floor of the mouth is that it isn't able to go through the series of movements that we all make after we eat, just to clean our teeth, just so that they feel nice and the food is out of there. So we're always, after we eat, using our tongue to clean the buccal surfaces, the cheek surfaces of the back of our teeth to get the food out of there. And one thing I often see in my adult patients with tongue tie is decalcification, orange or brown or white spots on the outside of the molars, or even cavities. And I often see people have had fillings done over the years in those areas, which otherwise is pretty unusual.
The anatomic results of our patient Mike's tongue tie are shown most clearly in the 3D model of his oral cavity and dentition.
So I'm going to use Mike's actual case as an example to show the constriction and so on of the arches as a result of his own tongue tie. So you can see here quite clearly that rather than the teeth coming out in a nice wide arch, they're crowded in the middle. And that's the same for the top and for the bottom. So they actually fit together really well at the back, which is great, but there's very little room inside for the tongue. And because you can actually see these teeth actually tipped inward, you can see how he would have a tongue biting issue there. Now, if we compare that with the arch of somebody who doesn't have a tongue tie, you can really see how dramatic the difference is. This arch is very wide, and this is natural. This isn't an orthodontic. Very nice and wide, and you can't see the full palate here, but it is a nice wide, fairly flat palate, whereas Mike's, you can see it's very narrow and it's high. It's what we call a vaulted palate. And Mike actually did have orthodontics as a teen, and I'm assuming that at that time he was given a wider arch with his braces, but over time, because he didn't have any sort of retainer holding them out, because he didn't have enough tongue width pushing the teeth out and keeping them in position, they relapsed and they crowded back inward. So if we also talk about the lowers, it's the exact same thing. These are the lower arches, and in Mike's you can see the same thing. There's this constriction through the middle, and there isn't enough space for all the teeth to be in line. So these ones were pushed buccally or outward, these ones were pushed inward, and then these two teeth on each side were also pushed inward. So there isn't room to make that nice good arch for a proper bite and proper space for the tongue. This is the tongue space in here. Whereas if you compare that to this arch, everything's nicely in line here, and there's a lot of room for the tongue. And there's a lot of room, because this tongue was not tethered, it was allowed to go through the whole sequence of movements that, ideally we go through from day to day, allowing the tongue to become wide and kind of muscular all around instead of muscular just in the middle. So we're going to use Anne-Marie as an example here of the full movements that an untethered tongue can make. So Anne-Marie, if you just open a little bit, you can see that she does have a little bit of a tongue tie, but if you just stick your tongue all the way out, you can see she has a nice long tongue, very normal, and a long anterior tongue, so the tongue tie hasn't actually impeded her. So Anne-Marie, if you just lick the buccal surfaces of your molars, you can see she can get her tongue all the way to the back of the molars to clean in there, and she does that every time after she eats without being aware of it. She goes in and cleans out any food that's jammed in between the teeth and around the teeth, and also around the bottom teeth she can do the same thing. So you can see also she doesn't have any fillings on the or decalcification on the outside of her molars, and that's because every day throughout her whole life she's been able to get in there and keep them clean.
A tongue tie is ideally released in infants to prevent feeding problems and speech problems and further orthodontic problems. It is never too late to release a tongue tie, though. It's better late than never. It will be harder in adulthood to reverse some of the orthodontic issues, but it will give the patient more freedom of movement, less fatigue after speaking, more than likely help with a speech impediment, and just give them an improved quality of life overall.
When tongue tie is identified at any stage of life, frenotomy should be considered. There can be genetic factors affecting oral structures, but tongue tie significantly increases the probability of these oral problems.